I'm Dr. Denise Waugh, and I work at Memorial Hermann Katy Hospital, where I've only been for 8 months now. And we have a brand new supportive medicine program there, which I am the team. And as I will tell you, palliative care or supportive medicine is best practiced with a full team, which involves a physician, a social worker, a chaplain in minimum. But when you start a new program, there frequently isn't quite enough funding. So you have to make sure that you present your case and show them that you can be helpful to their patients and to them before you get those other things. So fortunately, within the next month or so, I should get what's called a nurse coordinator, which will make my life much easier because somebody else will be scheduling things. But I was asked today if you're not in a meeting that is what to say when you don't know what to say, when there's really nothing to say, then you're in the wrong place because that's what I'm going to talk about for a very short period of time. I have to tell you that I have spent 30 plus years trying to learn to communicate better and to talk about the things that we're going to spend less than 30 minutes talking about today. I don't think there'll be much time for questions, but I will be at lunch today. So if you have burning questions, feel free to come up to me at lunch and ask me any questions you might have about it. And there is lots and lots, I mean, there is a huge amount of literature on this topic. And I'm so glad that that's the case because it's an area in medicine that until recently has not been a major focus. How I see things is happening, and I will describe palliative care and what it is, but just to start with how things have evolved over my career. Before I was in medicine, when I was a child and I was going to the doctor, there weren't so many things we could do about illnesses. Antibiotics were fairly new. There weren't a huge number of antibiotics to choose from. So, in that situation, the physicians really were in tune with communication and were in tune with death and dying because that was something that happened when people got sick. Fast forward that to today, when we have technological, I mean, many of you are survivors, if not all of you, of wonderful technological advances, which is great. But in my perspective as an emergency room physician for 25 years, the problem is that our communication skills have not kept pace with our tremendous knowledge of the science. So the science medicine in my estimation is best practiced as both an art and a science. And today we're going to talk about the art. And I'll talk with you a little bit like your medical students learning about the things that I have learned that have been helpful to me over the years, and I use very much on a daily basis now. Although I'm not really good with the acronyms, so I always have to look. You sort of integrate things over a while and just use them. But I think I'd like to start, and we'll probably end with nurse, NURSE, and what that means, because I think it will be helpful to you when you feel stuck. Nurse is to be used when the person that you're working with is very emotional and you want to have somewhat of a logical way of approaching, whoa, what am I supposed to do here? So nurse, the end of nurse is naming. So you want to try and name the emotion that they're having, but I would strongly recommend to you that you not say, I can see your, or I hear your, but rather, is it possible your, or am I sensing your, or I feel like your, feeling thus and so. Because if you commit yourself and say, you're angry, then if they weren't angry, you've really missed the mark and you've destroyed some of your closeness by pushing a little bit too hard or making too many assumptions. So the N is for naming it. When they seem upset, tell them, is it possible you're upset? Or is it possible you're feeling abandoned? Or whatever it is that you're sensing inside, it'll give you the feedback you need, and it will also let them know that you're really listening, not only to the words they say, but much of what we do in compassion is about sensing the words they say in more of a heartfelt type of nature. So the next in the NU is the U, which is understanding. So you want the person to know that you understand. But it is a real tendency of people in general to say, I understand exactly how you're feeling. Wrong. You will never understand, and that's what you want to say instead, is I can't possibly understand how you're feeling. Why? Because you didn't grow up in the same household, and you didn't grow up in the same rules, and every cancer is a little different, and every human is a little different, so we never fully understand each other. And you'll be on much firmer footing if you don't say, I understand totally, and rather say, I can't possibly understand. But by saying I can't possibly understand, you're actually showing them understanding, that you're reaching out to them, that you're trying to understand what they have to say. And the R, of course, is for respect. And very important that we continue to always be respectful of someone. There's a real tendency when we make ourselves the expert or the master that we put ourselves on a footing where we can't really express the compassion that we need to. S is for support. I think one thing that I've learned over time is to use we more than you. Because when you use we, and it sounds sort of funny initially to say we're going to go through this together, or we will see how things go. When you're, a stranger to their family, you're new in this relationship. But as you say the word we, it invokes the idea that you are not going to abandon them, that you're in this for the long haul, that it'll be we through this entire process. And then the E is for explore. So feel free to explore by open-ended questions. Try not to ask closed-ended questions. And you know the difference in that, right? What day is today? When did you first have this? And do you have that? Instead of saying, so tell me more about what you're experiencing. And are there other things that are coming across your mind, or other concerns that you have? Let them tell you where you want to go on this journey rather than you attempting to lead them somewhere. So to let you know what palliative care, I've just demonstrated part of what we do in palliative care. And as you think of some of the physicians that you've seen, I would suspect that what I'm telling you is a little different than what you've experienced with some of your physicians. So palliative care is a relatively new specialty. It is related to hospice, but it is not the same as hospice. I like to think of palliative care as being the big circle, and inside of palliative care is the small circle of hospice. So all hospice is palliative care, but not all palliative care. A huge portion of palliative care is not hospice. Palliative care is earlier upstream from the time of the diagnosis of a critical illness. In this case, a cancer illness. So from the very first moment the person gets that diagnosis, palliative care can begin to be helpful to that individual. Helpful to that individual because palliative care attends to the entire person, and medicine itself tends to pay attention to the physical person. You go there, many physicians would not recognize that they should be about relationships and about emotions and about the psychological and what about spiritual? How many physicians typically ask you about how much your spirituality has to do with your coping. But those are the kinds of things that if you really want to look at a patient as a whole, you need to bring in all of those things to help that person get the care that is appropriate for that patient. Um, Not the care, like palliative care isn't about saying, okay, it's an ABC thing. You have this diagnosis, so here's the first thing we do, and here's the second thing we do, and here's the third. And that's very helpful, and someone should be doing that. But palliative care is more about saying, how did you feel when you initially got the diagnosis? And how is your family coping with this diagnosis? Um, and are you a spiritual person? Has this made you question your spirituality, or has this given you greater strength? So you find out where people are on many different levels. So probably the best definitions that I found for palliative care, the one that the Center for Medicare uses as a definition, is that palliative care means patient and family-centered care that optimizes the quality of life by anticipating, preventing, and treating suffering in all its different facets. Palliative care throughout the continuum of care involves addressing physical, intellectual, emotional, and the spiritual needs while facilitating patient autonomy, access to information, and very importantly, patient choice. So you can have the same cancer, you can be the same age, you can be in a similar family structure, but how you decide a palliative team can advocate for you may be very, very different, because we all have had different stresses in our lives, and there's the people who are ready for the fight and who definitely want to fight. And then there's the people who say, I'm not willing to lose too much of my quality of life. From the time I was in medical school and long before I knew that I would eventually become a palliative care physician, in fact, I'd never heard of such a thing, I was thinking, I think if I got a cancer diagnosis, I would want to go on my absolute best vacation. And when I got back from my vacation, if there was time, then I would go about having chemo and that kind of thing. Now, that changed somewhat when I had children, because all of a sudden it's like, whoa, I've got to do everything I can to be alive for 18 years, to be there for my kids. So people change over time and their emphasis changes over time. But palliative care is not about saying you must do this. Palliative care is about saying here are the opportunities that are available to you. Which ones appeal to you? And do you know you have the power to say, no, no, this isn't what I want. What other things do you have to offer me, because this is not acceptable to me? So the Center to Advance Palliative Care, I've written that on there, and there's a website called capsi.org. So if you happen to be in Atlanta or someplace else listening to this, If you go to capsi.org and you look up your state, it will give you the names of palliative care physicians in your area, which we can use even here in the Houston area because not every hospital or clinic has palliative care. In fact, in Texas, we're a little behind both coasts, and there's not a lot of outpatient palliative care. Um, Memorial Hermann which is who I work for, is dedicated to the idea of trying to hire and bring in physicians to do and teams to do palliative care, both inpatient and outpatient. However, I can tell you that it's estimated in the United States right now there is one palliative care trained specialist for every 8,000 people that could benefit from a palliative care consult. So it's very difficult. The funding isn't there. We're not something that pays for itself, and because of that, it's been difficult to have enough physicians to go around. And as many of you know that are my age or within 10 years either direction, there's going to be a lot of us who need the assistance of our oncologist and need the assistance of a palliative care team in the next 10 to 15 years. So I've got the definition from CAPSI, and you can look at that. This black and white is just, the little one is hospice and the big one is palliative care. So if somebody comes in and says, I'm with supportive medicine or I'm with palliative care, don't think that your doctor decided things are going really poorly and we're trying to get you on hospice, because that is not what palliative care is about. Palliative care is about meeting you where you are on the journey, as you are going to be about meeting your compadres, the people that you are helping, wherever they are on the journey, and picking up with them. So much of what we need to do when we try and help others is respond to their emotions and allow and encourage them to tell their story. I understand that Can Care has changed a bit in their interpretation of what each of you will be doing with the other person. But what I'll tell you is it isn't about just listening, but it's about being a skilled listener who knows when to put in questions, and the questions are intended to stimulate the other person to explore answers. Because as you probably remember as a kid, when your mom told you, don't do that, but you were like, oh, that makes it, for some of you, oh, that makes it a little exciting. I wonder what really happens if you do that. And then you did it and you found out why it was that mom didn't want you to do that. But what did you learn the most from? From mom telling you or from exploring it yourself? So what you are going to try and do is help people explore their own answers, because their own answer may not be exactly yours. Believe me, they will ask you if they want to know more about your journey. But it's not about us telling them how we've coped, because how we've coped may have nothing to do with their basic skills. All of us come with a certain set of basic skills of how we cope with things. One of the more difficult patients are friends that you will share with are people whose major coping mechanism is denial. They want to deny that there's anything going on there. They've got a hole in the, I mean, this is a true story, a hole in the back of their chest from their pulmonary cancer, their lung cancer. And they worked in respiratory, so respiratory therapists should know about things like lungs. They've got a hole that you can actually see their lung moving in and out, but they are in denial that there's a major problem. Those patients can test us because we're like, how can we help them if they don't want to face the fact that there's even a problem? What I would encourage you to do, and this was difficult for me to learn, very difficult for me to learn, is again, you have to meet them where they are. If they're in denial and you attempt to remove that from them, what if that's their only coping mechanism? What do you have to replace that with that's better? Because you're not going to be living their life. You're not going to be there with them every day, every minute. And they need their own coping mechanisms. So, in the case of my gentleman, um, we talked about the needs of his family. We did not talk about his needs or his denial. He said, you know, when I need these things, I'll ask for them, but I don't need any of these things now. And so rather than approaching that, I went to the what does your family need? Would it be helpful to your sister if she was able to spend some time with you? Would you be willing to allow your family to help? Another thing that people frequently, they don't want to be a burden and they don't um, frequently, some people don't reach out. And you can't tell them that's not the way to be. You have to sort of go with the go with the flow and ask questions that allow them to explore where they are now, where they would like to be. As many of you, I'm sure, have experienced, one of the beautiful things about cancer, if you're a survivor, is many of you have lived with an intensity and a simplicity that you never experienced before. And it changes you. And if you survive it really improves how you function, how you cope, because you realize there's a lot out there that you can't explain, that you don't know is coming, and you have to learn to live how many of us that are more spiritual know that we're taught to live each day for today. Well, illnesses like cancer really reinforce enjoy every day you have, give meaning to every day you have. And I would suggest to you, when your patient gets a bad history, things have progressed, that you need to let them know through the questions you ask about what things are important to you now. What would you like to see happen in this circumstance? By helping them explore those things, you can help them transition their hope to the things that are important to them at this point in their life. And you can help it dawn on them that regardless of what their diagnosis is, regardless of how much time they have left, each of us does better if we live every single day. We don't want to close ourselves off close ourselves off to learning and to being and to enjoying because we don't have much time to enjoy. Some of the most meaningful things that I've ever seen happen with patients are patients that have had long-standing feuds with somebody and they don't want that person in their life, are able to say, now is the time. Now is the time for forgiveness, for bringing those things that are important to me together while I still have time. And I would suggest to you, when I was a younger person, that when I heard cancer, it gave me a bit of a, ooh, that sounds really awful. I would never want to have that. But actually, and I don't know if I've not had cancer, but I don't know if you'll understand this, but I've seen many patients deal with cancer. And I actually think that it's not one of the worst things you can have. I'd rather have cancer than have end-stage lung disease or end-stage heart disease, because you never know how things are going to happen with those. But at least with cancer, you have a little bit more perspective of, you've done everything you can do for me, and there's nothing we can do chemo-wise or radiation or surgery-wise. But I still have 4 to 6 months. So you have that time to complete your life, to do and say the things that you want to say to others, to experience things where all of the stupid stuff just goes away. Like, who cares whether you made it to the cleaners on Monday? You'll wear something else, you know? No problem. Those things are true blessings. And frequently, people that say that the problem is their end stage heart disease, no one knows exactly. The doctors can't tell them. They can tell them it's worse to have a 20% ejection fraction than it is a 50%, and that normal is going to be 60% or so. But they can't say what that means for. And don't we all want to know, what does this mean prognostically? How long do I have, doctor? Can't tell them. You can tell them that every time they get sick and they go in the hospital, they could die that time. But if they don't die, they'll come back up maybe pretty close to how they were before. And the only way they'll know they're getting close is when the episodes get closer and closer and closer together. That can indicate that their time is becoming shorter. So I no longer think of cancer as being the worst possible diagnosis that I could have. I think of it as being giving people the opportunity to say goodbye. I now think of one of the worst possible things that could happen is being hit by the Mack truck. I mean, it's simple for me. I don't experience anything, right? I'm hit, I'm dead, that's it. But for my family, for the unspoken words, um, it's really, really difficult. And I think most of us want to take care of our families near the end. So obviously, I could talk about this forever, but I think to understand what empathy truly is and isn't, it's to set aside our personal agendas, the story we want to so desperately tell it to each other. Let them ask you if they want to hear your story. So put aside your personal agenda and try and see the patient from their point of view. That's empathy, to put yourself, to walk a mile in their shoes. And you're going to have to explore some, because it's not going to be apparent to you exactly what their shoes are. But two major challenges to that have to do with what to say when there is nothing to say, which is to remain present when your own story begins to come to your mind while they're talking. Your own losses, your own grief, things that you didn't even realize were a major problem for you comes to mind. To remain grounded and centered and to listen empathetically in that situation is very difficult to do, but very helpful to the person you're working with. And the second, and this is really hard for people who think of themselves as masters, meaning any doctor, right? But also survivors of cancer. You've been through it, so you know, right? The urge is to act. The urge is to tell them how it should be done, or to try and do it for them. But again, remember that their learning and their ability to cope. Remember the story about somebody who's hungry and you give them a fish and somebody else teaches them how to fish so they can take care of themselves? That's what we want to do for the people that we're working with that are going through cancer, is we want to teach them how to fish. We can't give it to them and then take it in and be able to utilize it. So the rest sort of goes through like how you go through the process. How many? Okay. So many of you know the uh-huh. I mean, you talk on the phone with your friends, or you're sitting there and you're like, uh-huh. And the more interested you are in the story, you lean forward and you go, yeah, uh-huh, uh-huh. Well, those are minimal leads and active verbal following. But in addition to that, and this one is a little harder, but you'll see that it's very helpful, is to say, oh, and then what happened? And what did you think? So again, it's not about you not talking, it's about you using words that bring them out so they give you more information. Because just that, being empathetic and listening while asking open-ended small questions or doing the uh-huh is therapeutic for them. You're not going to cure their cancer. You're not going to make all their problems go away, but just to listen to what their problems are is very therapeutic. I've been in situations where I've walked away thinking, oh my goodness, did I help at all? For me, it's very difficult. I can definitely identify with women who have younger children at home and the horror of having something like cancer when you have young children at home. So what I've been amazed by is the young women who say to me, oh, doctor, you've helped so much. And I'm like, what'd I do? I just listened. But in this world, in 2019, to truly, empathetically listen to someone is a rare gift, and a gift that each one of you in this room can offer to the person that you're working with. Thank you so much for what you do. You reach out in a way that there aren't enough people like you around to do, that you have gone through the fire and are willing to hold somebody else's hand as they go through the fire is an amazing, amazing thing. And I appreciate each and every one of you for doing that. So if you need access to palliative care, again, you can go on CAPC.org. You can call your hospital administration close to where you are and find out if they have palliative care. A few of our oncology clinics have embedded palliative care services. But by the way, in case you think, oh, I'm going to MD Anderson and they have a huge palliative care department, that you will have exposure, not necessarily so. You need to ask for what you need, and you need to strengthen the people that you work with to ask for what you need. Do you have palliative care? I'd really like to see a palliative care person. Some oncologists will be slow to ask for that. They equate palliative care to hospice. Is there any wonder that the lay public is, clueless when there are physicians who still think they're the same thing? Believe me, they are not. And one of my favorite things to do is to work with a cancer patient, because we can talk about if it does get better or if it doesn't, and what that'll look like, and plant those seeds, hoping for the best, but preparing for everything else. Thank you so much.